Started? Okay. Okay. Good evening, guys. Welcome back. So we are discussing about the cardiac pathology. Okay. We have completed all the major topics in the cardiac pathology. Now today we have to start with the gastrointestinal pathology. Now in the gastrointestinal, before starting the gastrointestinal pathology, we are left with a small topic. Okay, we are left with a small topic from the cardiovascular pathology. Can you guess what is that small topic which we have left in the cardiac pathology? The one small topic which we have left in the cardiac pathology. That's the cardiac tumors. Okay, let's do the cardiac tumors for the a little amount of time, and let's close the cardiac pathology and let's directly jump into the gastrointestinal pathology. So gastrointestinal pathology will be going to start in 10 minutes. The first 10 minutes, let's do the cardiac tumors. So let's write cardiac tumors. Cardiac tumors. Now my question to you, what are the most common cardiac tumors? The most common cardiac tumors are, what do you think? Most common cardiac tumors are always secondaries, which means usually in the heart, tumors do not originate. They won't, there won't be any cancer to the heart cell. Okay, usually speaking. So there will be metastasis from secondary sites. Okay, the lung cancer, liver cancer, breast cancer, there will be secondary metastasis to the heart. Okay, so secondaries are most common. If there is a tumor in the heart, most probably the tumor is not originating in the heart. Somewhere else in the body the tumor have originated, the cancer have originated, and these cancer cells have metastasized into the heart, and there they are growing. Okay, in the heart they are growing. And what is the most common site? What is the most common site of the secondaries where they will grow? In right atria, left atria, right ventricle, left ventricle, or where, sir? It's not the chambers of the heart, it's the pericardium. Okay, it's the pericardium. Okay, it's the pericardium. Is the most common site for the metastasis in the heart, in the pericardium. Now you can ask me, sir, then what is the primary site where the cancer is originating? Which cancers will highly likely to metastasize to the heart? Okay, so heart is just surrounded by lungs, very much near. Okay, heart is here, lungs are here. So the primary site, okay, the primaries which are coming have originated from the lung. So it's the lung cancer which is metastasizing to the heart, and in the heart, in the pericardium, they are growing. Okay, so these are the points which I want you to know. Now after this, let's discuss about the cardiac tumors in children as well as adults. Okay, there is a little difference. Cardiac tumors in children, sir, and adults. So why we are differentiating, it's because the most common tumors, okay, the most common tumors in the children and the most common tumors in the adults are going to be different. So what is the most common benign tumor in the children? What is the most common benign tumor? Benign, these are the primary tumors. These are the primary tumors that are arising in the heart. Okay, I am not talking about the secondaries. These are the primary tumors that are arising in the heart. Okay, benign as well as malignant. Malignant. So now the answer is rhabdomyoma. So rhabdomyomas are the most common benign tumors, benign cardiac tumors in the children. Okay, now malignant, rhabdomyosarcoma. Okay, rhabdomyosarcoma. So sarcoma is a cancer. Okay, now in the adults. Okay, in the adults, what is the most common benign tumor? The most common benign tumor in the adults is going to be myxoma. We'll discuss about them one by one. Myxoma. And the most common cancer in the heart. Okay, it's going to be the malignant tumor in the adults is going to be angiosarcoma. Okay, angiosarcoma, sir. Okay, angiosarcoma. So these are some important points which I want you to know. See, generally if they ask you, what is the most common primary cardiac tumors? Okay, most common they haven't asked whether it's a children or adult. They haven't mentioned anything. What are the most common primary cardiac tumors? The answer is going to be myxomas. Okay, myxomas. Okay. So after this, now let's begin with the topic of myxoma. Okay, I have said you the myxomas are going to be the most common tumors. Now let's begin with the myxoma. So now tell me, myxomas are going to be most commonly seen in the adults or children? Definitely in the adults, definitely in the adults. So what's the age group that's going to be affected? So the age group that's going to be affected is going to be the elder age groups, not just younger age group, elder age groups, somewhere around 40 to 60 years. So if there is any sex predisposition, like like most commonly going to be seen in which sex? So the sex is that's going to be most commonly associated or affected is going to be females. Okay, females. Now you can very clearly see here. So this is the myxoma. Okay, which is also called as the atrial myxoma. Okay, atrial myxoma. So it's a tumor, sir. It's a benign tumor. It's not a cancer. It's a benign tumor that is occurring in the left atrium, the most common site. The most common site of this tumor. Okay, the most common site of this tumor is left atrium. Okay, next. The other important points which you need to know for your exam is, they go, sir, let's put it this way. See, these are the four chambers of the heart. Okay, four chambers of the heart: right atria, left atria, right ventricle, left ventricle. Now here, this is the intraatrial septum. Okay, this is the septum. Here will be the fossa ovalis. From here, from this area, a pedunculated tumor. The tumor is not a sessile tumor, sir. It's actually a pedunculated tumor. It's having a stalk. It's having a stalk. So this tumor, it will move, sir. It will move. It's going to be dangling over there. It's going to be dangling. Okay. So as it is dangling over there, it will cause some sound, murmur. Okay. So what is that sound that's going to be seen in cardiac myxoma? The answer is going to be tumor plop sound. Tumor plop sound. Okay, so it's a low intensity heart sound. Okay, it's a low pitch heart sound, I should say. It's a low pitch heart sound. Okay, you know S3, S4 and tumor plop sound. S3 is the low intensity sound, S4 is a low intensity sound. In the same way, I should say low pitch. Okay, S3, S4 and this tumor plop sound, all these are going to be low pitch heart sounds. Okay, which are heard with the bell side of the stethoscope. Now, when it is going to be seen? So, it's going to be seen when? It's going to be seen mainly during diastole. It's a diastolic sound. Okay, it's a diastolic murmur. In your exam, okay, they will give you, in a case they will give you something like this. These are the classical words they will use. What are they? They will use something like low intensity heart sounds. That is nothing but the tumor plop sound. Low intensity heart sound heard after opening snap. Sir, what is opening snap? That and all, they're all the topics of physiology, sir, the basic physiology. Okay, opening snap, ejection, click. Okay, S1, S2, S3, S4 heart sounds. So after opening snap means, just for your general understanding, I am telling you, opening of the mitral valve and tricuspid valve. When the mitral valve and tricuspid valve, whenever they opening of these valves will also cause a sound which is called as the opening snap. So after opening snap, if you hear low intensity heart sounds, then you have to think about that the patient is having this atrial myxoma. So this is a keyword. Low intensity heart sound heard after opening snap. Okay. Next, you just tell me, sir, when this patient is going to have the maximum symptoms, what do you think? When the patient is going to have the maximum symptoms, usually you know. So when the patient is going to lying down position, okay, imagine now the patient is going to lying down position. Okay, he's standing and he's going to the lying down position. Whenever he is going to lying down position, more venous return is going to be there to the heart, more blood is going to the heart, so more preload on the heart. Okay, usually if I am the patient who is having heart failure, congestive heart failure, so whenever I go into lying down position, more venous return to the heart, more preload, more end-diastolic volume, so more load on the heart. So my symptoms like dyspnea are going to be aggravated. Okay, so with lying down position in all the cardiac disorders, with lying down position, what happens to the symptoms like dyspnea Our pulmonary congestion increases. But in this condition, when do you think more symptoms are going to be seen? During standing. Whenever the person is standing, not lying down, when the person is standing, this tumor, maybe it is a big tumor, it will come and block the mitral wall. The ball is nothing but the tumor. It will go and fit in the wall. Okay, ball in wall phenomenon. It can cause mitral stenosis. It is now totally blocking the wall and causing symptoms like mitral stenosis. So this is something called as platypnea. Okay, so what I have discussed here is platypnea, which means the person is having symptoms. When he is standing. Platypnea, sir. Okay, so that's the one point I want you to know. Next, associations. See, this myxoma, it is associated with something called as Kearney syndrome. Okay. So what exactly is the Kearney syndrome? You can ask me. So Kearney syndrome means, look here, first let me show you. See here, Kearney syndrome or the Kearney's complex. See, the patient is going to have heart myxomas. So the patient is going to have the myxomas in the heart. Apart from the myxomas, the patient is going to have this lentiginosis, that is a pigmented skin lesion. The pigmented skin lesions can be seen. Okay, see, the skin myxomas are going to be seen. Apart from that, the patient can also have the endocrine related problems. Are going to be seen. So let me write here. So in Kearney syndrome, the patient is going to have myxomas. So myxomas, they are the benign tumors. Again, I am telling you, they are not the cancers. Myxomas, pigmented skin lesions, as well as endocrinopathies. Okay, endocrine related problems can be seen. Okay, endocrinopathies can be seen. So these are some important points which I want you to know regarding the myxomas. Now, what are the complications that are seen? Associations completed, Kearney syndrome. What are the complications? Let me write. See, these myxomas, these tumors, small tumors, they might embolize. Okay, they will detach and they might embolize. If they embolize, what they will do? They will cause stroke. So these patients are at risk of stroke, sir. Okay, these patients are at risk of stroke. Not only that, this myxoma, okay, now it is continuously hitting. The mitral wall. Okay, it's continuously hitting the mitral wall. So initially there will be valvulitis, valvular damage is going to occur. So there is a possibility of mitral regurgitation. There is a possibility of mitral regurgitation due to the damage to the mitral wall. Or I have said you, this tumor, it will go and fit. It will go the ball in the wall due to this ball in wall phenomena. Okay, that can block the mitral wall, so leading to mitral stenosis. Symptoms of mitral stenosis. These are the complications that can be seen with the myxoma. Okay, stroke, mitral regurgitation, or mitral stenosis. So with this, what we have completed? We have completed the cardiac tumors also. Okay, cardiac tumors are done. If you know this much, it's enough. Mainly, I want you to know about the myxoma. Okay, so having said that, now let's begin with the gastrointestinal pathology. Sir. Just give me a minute. Let me take the slide of gastrointestinal pathology. Yeah. So let's begin with the gastrointestinal pathology. Okay. Now just wait 1 minute. Let me add a slide. Okay, done. Now look here. So what you are looking here is the layers of the GIT. Okay, there are 4 layers in the GIT. Okay, yeah, there are 4 layers in the GIT sir. What are the 4 layers in the GIT? See, the innermost layer. Okay, even in your physiology you have studied this. I hope you have already studied this. See, the innermost layer which is present over here, this is called the mucosa. Mucosa is present, sir, done. Now this white color layer, okay, which I am highlighting right now, this white color layer, this layer, this is called as the submucosa. Mucosa is there, done. Submucosa is there, and after submucosa, what is this red color layer? The muscle layer. It's called as the muscularis, and the last layer is the serosa. So mucosa, submucosa, in an easy way you can understand. The innermost layer is called as the mucosa. The mucosa is surrounded by submucosa. Submucosa is surrounded by muscularis, and muscularis is surrounded by serosa. So this is how the GIT is arranged, the layers, okay, the 4 layers of the GIT from inside to outside. Now look here, the point which I want you to know is, so in the mucosa, in the mucosa, are you able to appreciate this cell, like this network of neurons, the network, these yellow color things are the neurons, the wire like structures are the neurons. See, these neurons are present, there is a nerve plexus present in the submucosa. This nerve plexus is called as, it is called as the Meissner's plexus, okay, done. Meissner's plexus or submucosal plexus. Not only that, in the muscularis also, even in the muscularis, there is this nerve plexus present. The same nerve network is present in the muscularis also. This network is called as the myenteric plexus. This network is called as the myenteric plexus. So there is Meissner's plexus as well as the myenteric plexus. Meissner's and myenteric plexus. Now my question to you, so in your GIT, there are almost 100 billion neurons are there. Now my question to you, this is also called as the enteric nervous system. My question to you is, so the neurons are supposed to be present in the nervous system. The neurons are supposed to be present in the nervous system. Then how come these neurons came into the GIT? How? Sorry. How these neurons have came into the GIT? So that's the question, sir. That's the topic which I want you to know is, sir, there is something called as neural crest cell migration. Okay, neural crest cell migration. So what is this neural crest cell migration? See, when you are an embryo, okay, there is a development of the neural tube. Okay, there is development of the neural tube. Now there is anterior neural pore and the posterior neural pore. Okay, anterior neural pore and posterior neural pore. You know it. This neural tube, sir, this neural tube is the one which develops into the brain. Okay, brain and spinal cord. Okay, brain and spinal cord. See, this neural tube is the one which is going to, in the future, is going to develop into the brain and spinal cord. But that's not the one which I want here. See, surrounding this neural tube, there are this neural crest cells present. Okay, there are certain cells called as the neural crest cells. These neural crest cells are naughty cells. Do you know? They are not going to stay in one single place. Now they are going to migrate. These are the neural crest cells. The neural cells, they will start to migrate. Now these neural crest cells, right? Neural crest cells are going to what? Do what? Migrate. Okay, so there is the neural crest cell migration. Now these neural crest cells, they will come into the GIT, and in the GIT they forms Meissner's plexus and myenteric plexus. Okay, the Meissner's plexus and myenteric plexus. So this is how the neurons or the neural cells have developed in the GIT. It's because of what? It's because of the neural crest cell migration. It's because of neural crest cell migration. Okay, now you can ask me, so why we are discussing all these things in the pathology? It's because now we are going to start with a topic which is called as congenital anomalies. Okay. Congenital anomalies. In the topic of congenital anomalies, what if there is defect? What if there is defect? defect in what? In neural crest cell migration. Okay, neural crest cell migration. Now, let me put it in a simple way. Imagine, look at here. Dekho sir. Now, this is, this is the colon, right? Ascending colon, transverse colon and descending colon. Ascending colon, transverse colon, descending colon, sir. Okay. Now, to this particular part, the neural crest cells are not migrated. To this particular segment, the neural crest cells are not migrated. So there is no development of the mesenteric plexus and there is no development of the myenteric plexus. No mesenteric plexus, no myenteric plexus, sir. Okay, simple. No mesenteric plexus, no myenteric plexus. When mesenteric plexus and myenteric plexus, whenever they are not there, okay, now do you think peristalsis can happen? No. The myenteric plexus is the one which helps in the peristalsis. The myenteric plexus are also called as the R-back plexus. The myenteric plexus or the R-back plexus is the one which helps in the peristalsis. Now, whenever there is a defect in the neural crest cell migration, to this particular segment, the neural crest cells didn't came. Simple. No mesenteric plexus, no myenteric plexus. So, food is coming like this. Imagine the food bolus is coming like this. Let me put it in a simple way so that you can understand. The food bolus is coming like this and the food bolus came to this area also. Okay, food bolus came to this area. Now from this area, do you think the food bolus will go down? Will it go down? Will it move further? No, because there is no peristalsis. So this food bolus is not able to move forward. But at the end of the day, it should move, right? It should move. Otherwise, it will be totally blocked. Okay, there will be total blockage. So now what happens in order to push this food, in order to push this bolus, so the proximal segment, this part, the proximal segment will start to do more work in order to push the food forward. As the food is getting accumulated, to push the this bolus forward, the proximal segments will start to work hard. So what happens? So there will be hypertrophy. Okay. So the colon will become bigger. So the colon, the proximal part, okay, is going to become bigger in size. So this colon is called as aganglionic megacolon. Okay, aganglionic megacolon, which is also called as Hirschsprung disease. Hirschsprung disease. Okay, Hirschsprung disease. So Hirschsprung disease or aganglionic megacolon, what is the problem? The problem is neural crest cell migration defect. Neural crest cells are not going to be migrated to that particular part of the colon. Okay, especially the colon. So now it is seen in which persons? So associated with the Down syndrome. Okay, associated with the Down syndrome. Now, whenever you take the biopsy from this segment, okay, aganglionic segment, whenever you take the biopsy from this segment, now you are not going to see any mesenteric plexus or myenteric plexus. So mesenteric plexus and myenteric plexus are absent, and the ganglionic cells, there are cells called as the ganglionic cells, which are also derivatives of the neural crest cells. Ganglionic cells are going to be absent. Okay, on biopsy, what you will see? Biopsy, absence of mesenteric and myenteric plexus. And the ganglionic cells are also absent. So as simple as that. Okay, as simple as that. Associated with the Down syndrome. So the first congenital anomaly I have completed, sir. The first congenital anomaly is completed. Now let me show you the images also. Okay. See, look here. See how big the colon is. Okay, this is the aganglionic megacolon, and you can see. Okay, we can very clearly see, sir, in this contrast study. Okay, in this contrast study, you can very clearly see the barium enema. You can very clearly see that the patient's colon is too much dilated. Okay, so diagnosis is going to be like made on clinical presentation, rectal biopsy. After this, the second congenital anomaly that I want you to know is the tracheoesophageal fistula. Okay, the tracheoesophageal fistula, sir. So guys, do you have any idea about the tracheoesophageal fistula? Let's make it as simple as possible. The name itself is there. Dekho. Tracheoesophageal fistula. There is an abnormal connection. What exactly is a fistula, sir? Fistula is illegal connection, sir. Illegal connection or the abnormal connection. Okay, for easy understanding. Okay, there shouldn't be any connection, but if there is some abnormal connection between the two hollow structures or the two cavities, then it is called as a fistula. Now, in between which structures there is this abnormal connection present? The tracheoesophageal fistula, it is present between the trachea and esophagus. Between the trachea and esophagus there is an abnormal connection. Okay, so they will ask you why. So the tracheoesophageal ridges, okay, are supposed to be fused. Okay, the tracheoesophageal fish, like when you do your embryology, you will understand. Okay, tracheoesophageal ridges, actually they will fuse by 4 weeks of intrauterine life. Like by 4 weeks of intrauterine life, the tracheoesophageal ridges are supposed to be fused. Whenever they are not fusing properly, failure of tracheoesophageal ridges fusion, it will lead to tracheoesophageal fistula. How many types of tracheoesophageal fistula are there? There are 5 types of tracheoesophageal fistula. Okay, type A, B, C, D, E. Okay, there are 5 types. Now, dekho, here I am showing you the 5 types of tracheoesophageal fistula. Okay, tracheoesophageal fistula. Now, let's go by one. Sir, what is the most common type of tracheoesophageal fistula? The most common type of tracheoesophageal fistula is type C. Okay, type C, dekho. 86%, sir. 86% type C. Now, in type C, please try to appreciate. So, this is the esophagus. Blunted. Okay, there will be totally esophageal atresia. The esophageal atresia, sir. Done. The distal part of the esophagus, see, the distal part of the esophagus is starting from the trachea. The esophagus is now in connection with the trachea. Now, whatever he is breathing, that air will start to go into the stomach. Right, simple. So, whenever the baby is feeding, whenever you feed the baby, now imagine, this is the baby, sir, now a newborn baby. Now, what you do with the newborn baby, you are going to give it to the mother, so the mother is going to do the breastfeeding. Okay, lactation. Now, whenever this baby, drinks the milk, what happens? The milk is coming like this and the milk cannot go further. Immediately the baby is going to do the vomiting. Okay, the baby is going to have the vomitings. The baby cannot drink. So, you think like this, whenever there is this newborn and whenever the baby is drinking the milk and immediately is doing the vomitings, he cannot drink. Think about the tracheoesophageal fistula. Okay, 86% type C variety. Okay, with distal tracheoesophageal fistula is arising from the, distal tracheoesophageal fistula. Yeah, this area, sir. Next, in type A, what exactly is happening? Type A is little important. Okay, because in type A, the esophagus atresia is the esophagus have undergone atresia. And this is the distal esophagus, but there is no fistula. Okay, in type A, there is no fistula, sir. There is no abnormal connection. Okay, in type A, there is no abnormal connection. It is just 8%, sir. Okay, done. Now, in type E, sir, this is the trachea, okay. Esophagus also okay, but there is a fistula present. But is there any atresia present? There is no atresia. So, that's the important point. In type E, without atresia or H type, it's looking like a H type, right? Okay. So, type C is most common, sir. Okay. Type C is most common. Type A, there is no fistula. In type E, there is no atresia. In type A, there is no atresia, sir. Okay, done. In type B, so in type B, there is atresia. Okay, dekho. Here there is atresia. Esophageal atresia is there, and fistula is also present. Proximal tracheoesophageal fistula, sir. Okay, this is very much important, especially for your the PG exams. Okay, so generally for the FMG exams, they won't ask you in that much detail. Image based questions are not going to be that much detail, that much important for your FMG exams, but for the PG exams, it's very important. Okay, so esophageal atresia is going to be seen with fistula that's going to occur in the proximal esophagus. Then type D, so esophageal atresia is seen with the proximal tracheoesophageal fistula as well as distal tracheoesophageal fistula are there. So both proximal and distal tracheoesophageal fistula are there. So done, sir. Okay, so these are some important points which I want you to know. Okay, so I have already taught you, if there is tracheoesophageal fistula, the boy or the baby is going to have the choking. Whenever he takes the milk, will be immediately choking, sir. Choking. Because why choking? You can ask me. Why choking? Because see, in certain varieties, the food or the milk, whatever he's taking, it can enter into the trachea, possible. Okay, it can enter into the trachea. So when the food is entering into the trachea, automatically there is going to be choking, no doubt. Okay, so choking or coughing upon feeding. Okay, there will be cyanosis also. Cyanosis is going to be seen in these babies because of this fistula. Okay, done. After this, the next topic which I want you to know is esophageal diverticulum. Okay, let me take the heading. Esophageal diverticulum. You know it, esophageal means esophagus. Diverticulum means what? Diverticulum means a pouch. Diverticulum means a pouch. Now, this is a simple image, okay, which I have found it in the internet, simple image. Now, so this is the trachea, okay. Back to the first, initially we are going to have the trachea. Back to the trachea, who is there? Esophagus, sir. Done. Now, see, this is the pharyngeal muscle, okay. This is the, on top side, there is thyropharyngeus, okay. Now, below it, there is cricopharyngeus, thyropharyngeus and cricopharyngeus. Now, both this thyropharyngeus and cricopharyngeus, again and again repeating. On the top, there is thyropharyngeus. Below, there is cricopharyngeus. Thyropharyngeus and cricopharyngeus. Both of them, they are forming inferior pharyngeal muscles. Okay, inferior pharyngeal constrictor muscles. Okay, done, sir. So what? Now, what happens in these patients is, so let me show you. Again, here also same. There go. So this is thyropharyngeus. This is cricopharyngeus, thyropharyngeus and cricopharyngeus. In between these two muscles, there is a weak point, sir. There is a weak point present here. This weak point is called as a Killian's dehiscence. So now tell me, Killian's dehiscence is present between, sir, Killian's dehiscence is a weak area which is present between the thyropharyngeus and cricopharyngeus. Now, whenever there is abnormal pressure developed in the pharyngeal region, because of some region, if there is some high amount of pressure that is getting developed in the pharynx. Okay, now what happens? Now, through this weak area, the mucosa is going to herniate out. So, look here what is happening. Dekho sir here. See? Now, dekho what is happening here. So, there is protrusion of this mucosa through this weak point. So, this is called as Zenker's diverticulum. Okay. So, now tell me, what is the most common site of Zenker's diverticulum? The most common site of the Zenker's diverticulum is going to be Killian's dehiscence. Where exactly Killian's dehiscence is present? Sir, Killian's dehiscence is the area, okay, Killian's dehiscence is the area which is present between the thyropharyngeus and cricopharyngeus. Okay, done. Sir, is it a true diverticulum or false diverticulum? It's an example of false diverticulum. Why it is called as false diverticulum? Because see, not all the layers are involved. If all the layers, mucosa, submucosa, serosa, muscularis, if all the layers are involved in forming this pouch, diverticulum means a pouch. If all the layers are involved in this pouch, then it is called as a true diverticulum. Now look here, see in the pseudo diverticular, the false diverticular, देखो, only the mucosa or even the submucosa, only the mucosa or submucosa are involved. Not all the layers are involved. If all the layers are not involved, then it is called as a pseudo diverticulum. Okay, pseudo diverticulum. Okay, so Zenker's is an example of pseudo diverticulum. Okay, so one by one points. Now I am going to start. I have started with the Zenker's diverticulum. So the Zenker's diverticulum is an example of false diverticulum because not all the layers are involved, not all 4 layers are involved. What is the most common site of the Zenker's diverticulum? So Zenker's diverticulum is going to arise from an area called as Killian's dehiscence. Where exactly the Killian's dehiscence is present? Killian's dehiscence is present between thyropharyngeus and cricopharyngeus. Okay, done. So, whom it is seen, sir? In whom it is seen? This Zenker's diverticulum. So, this Zenker's diverticulum, it is seen in old men. Okay, it is seen with old age, MCQ. It is seen in the old men, sir. Okay, with age, it's going to be seen. What is the most common symptom? If there is such a pouch, if there is such a pouch which is hanging, back to the esophagus, do you think proper swallowing is going to occur? No, proper swallowing is not going to occur. So there will be difficulty in swallowing. Okay, difficulty in the swallowing. See, now look, what exactly happens is when the patient takes the food, now this food, it will enter into the esophagus. The glottis is going to be closed. Okay, the food have to enter into the esophagus. Now, not only that, now because of this diverticulum, dekho, here there is a diverticulum. Now, this is the Zenker's diverticulum, sir. Okay, now because of this diverticulum, the food will also start to fall into this diverticulum. Now, this diverticulum from backside, it will start to compress the esophagus. So, there will be difficulty in swallowing. Not only that, this food is going to come and get settled over here, and now this food, there is no chance that it's going to go back into the esophagus, so it's going to get decomposed over here. Okay, it's going to get decomposed over here. So what is happening? So now they'll be decomposing, the food is getting decomposed over there, and there's going to be bad breath. There's going to be bad breath, sir. So halitosis is going to be seen. Okay, so halitosis is going to be seen. Halitosis, what exactly is the halitosis? It's a bad breath. Halitosis means bad breath. Okay, so now let me highlight one by one. So Zenker's diverticulum, it is seen, in most commonly in old men. The most common symptom is going to be dysphagia and halitosis. Okay, that's a bad breath coming. Okay, so why bad breath? Because of the decomposition of the food in that pouch. Okay, so what is the most common complication? The most common complication is going to be, sir, when this patient is sleeping, okay, in the lying down position, this food may aspirate into the trachea. The food may aspirate into the trachea. So when the food is getting into the trachea, that's not good, sir. Aspiration is not good. Okay, so the most common complication is going to be aspiration. Okay, this aspiration may lead to the lung abscess. So this is the most severe complication, sir. Not just the most common, it's the most severe complication. Okay, so what is the investigation of choice? In many exams, NEET PG exams, FMG exams, this question was asked. You have given the barium swallow. You have asked the patient to drink this barium milk. Okay, barium. The patient is drinking this barium milk. Now, immediately after drinking, okay, immediately after swallowing, you have taken the X-ray. Now, there you go. Sir, are you able to appreciate this pouch? Okay, this is the normal esophagus. Are you able to appreciate this hanging structure? That's nothing but the pouch. That's the Zenker's diverticulum. Okay, Zenker's diverticulum. So Zenker's diverticulum, it's actually arising from the pharynx. It's actually arising from the pharynx, not exactly from the esophagus. It's arising from the pharynx. So that's why this Zenker's diverticulum is also called as, pharyngeal pouch. Okay, it's also called as what? It's also called as pharyngeal pouch. Right? Now, after this, what is this investigation of choice? Investigation of choice is going to be barium swallow. Now, my question to you, what is the surgery that you are going to do with these patients? Okay, let me show here. See, you are going to remove the septum. Okay, you are going to remove the septum. Okay, now, so that what happens? Whatever the food is there, now it's going to pass down. Okay, there is no going to, the food is not going to accumulate now. You have removed that wall, so that you have made it now one single cavity. You have made it into one single cavity. So what is the surgery that is done? Any idea, guys? Guys, do you have any idea what is the surgery done? Any idea, guys? Come on, fun mode, Osama. Okay, let me start to answer your questions. So come up with the dermatology classes. Yes, we'll plan for that. Okay, you can personally ask bonus for the dermatology classes. Come on, fun mode. What is the surgery? Any idea? Very important MCQ. Dolmans, it's called as Dolmans. Okay, Dolmans endoscopic surgery. Okay, the surgery which I have shown you here in this image, it's called as a Dolmans endoscopic stapling surgery. That is done for the pharyngeal pouch. That is done for the pharyngeal pouch or esophageal diverticulum. Now, after this, let me discuss about the different types of diverticula. Okay, different types of diverticula in the esophagus. Now, for your exams, this is a little important topic. So, let me draw. Let me show you something like this, okay? Now, you know, this is the esophagus and this is the diaphragm. Here I am showing the diaphragm, sir. Okay? Done. Now, see, you can have the pouch, okay, this pouch or the diverticula in the topmost area. okay, in this topmost area. So what is this? In the region of the pharynx, this is Zenker's diverticulum. Okay, you know about the Zenker's diverticulum, that's a false diverticulum. Okay, now you can have this diverticula in the middle one third of the esophagus. Okay, in the middle one third of the esophagus. See, these diverticula which are seen in the middle one third of the esophagus, they are called as a traction diverticula. So this traction diverticula are seen in which conditions? So this traction diverticula are seen in certain conditions like diffuse esophageal spasm. I will talk about this diffuse esophageal spasm, but just remember, in a patient who is having diffuse esophageal spasms, okay, in a patient who is having diffuse esophageal spasms, he is going to have traction diverticula. Okay, diffuse esophageal spasm, DES. Remember DES, diffuse esophageal spasm. One are mediastinal fibrosis. In both these conditions, diffuse esophageal spasm and mediastinal fibrosis, the patient can have traction diverticula. Now, there can be formation of the diverticula in the lower one third, of the esophagus. Okay, this is the middle one third, this is the lower one third of the esophagus. See, these diverticula are present where? These diverticula are present just above the diaphragm, So, these are called as epiphrenic diverticula. Okay, epiphrenic diverticula. Okay. These are called as epiphrenic diverticula. See, this epiphrenic diverticula, before telling you about the epiphrenic diverticula, let me write one important point. So, this traction diverticula, which are seen in diffuse esophageal spasm or the mediastinal fibrosis, they are true diverticula. Okay, they are the true diverticula. The traction diverticulum is the example of true diverticulum seen in the diffuse esophageal spasms. Now, epiphrenic diverticula. So, this epiphrenic diverticula, they are seen in which conditions? They are associated with gastroesophageal reflux disease, GERD, gastroesophageal reflux disease or achalasia. Okay, achalasia cardia. You know, right? Achalasia cardia. Okay, Achalasia cardia and gastroesophageal reflux disease are associated with epiphrenic diverticula. Traction diverticula are associated with the diffuse esophageal spasm, and Zenker's diverticula. You know, Zenker's diverticulum are going to be seen, seen in the older males, and this diverticula is going to arise from the pharynx, from a region called as Killian's dehiscence. Done. Now, this epiphrenic diverticula is an example of true diverticula or false diverticula. This is also false diverticula. This is also an example of false diverticulum, not a true diverticulum. Okay, only true diverticulum here is traction diverticula, other true diverticula. Having said that, now let's begin with the topic Achalasia cardia. Okay, Achalasia cardia. So what exactly is the problem in Achalasia cardia? Esophageal disorder. Now I am going to start with the esophageal disorder, sir. Okay, diverticular completed. Now what exactly is Achalasia cardia? See, Achalasia cardia means loss of relaxation of lower esophageal sphincter. The lower esophageal sphincter, it was supposed to relax, right? Whenever you take the food or whenever you take like a food or some liquid, it have to relax. It have to allow the food from the esophagus into the stomach. Now, there is loss of relaxation of the lower esophageal sphincter. Okay, why? Why loss of relaxation? The reason is decrease, or I should say loss of inhibitory neurotransmitters. Normally, for the relaxation of the lower esophageal sphincter, you require nitric oxide. Nitric oxide is the one which helps in relaxation of the lower esophageal sphincter. That's going to be decreased. And VIP, vasoactive intestinal peptide. Okay, so this VIP and nitric oxide. The VIP and nitric oxide levels are going to go down in this disease. Whenever they are going down, the relaxation is not going to occur, loss of relaxation. When there is loss of relaxation, the lower esophageal sphincter is not getting relaxed. So what are the clinical features are going to be seen? Which clinical features are going to be seen? The clinical features are going to be dysphagia. Cannot swallow the food. Okay, he's taking the food but it's not going down. So there will be dysphagia. But important MCQ, seen in whom? Affects children, males or females. Okay, which sex, sir? Which sex? And which age group? Affects young age group, young females. MCQ, young females, going to be seen in the young females. What is the clinical features? There will be progressive dysphagia. Okay, it's going to be, yes, Ashutosh, you are true. There is going to be progressive dysphagia, which means initially the patient is having difficulty to swallow the hard foods, like solid foods. Okay, whenever the patient is taking the solid food, it's a little difficult. Okay, but later on, even there will be dysphagia for the liquids also. Even taking liquids also will be very much difficult. So initially the dysphagia is seen for the solid foods, followed by even the dysphagia is seen for the liquids. And importantly, there will be more dysphagia for the liquids. Okay, progressive dysphagia is seen, and liquid foods, taking liquids, we will be having more dysphagia. So the patient is going to have more dysphagia while taking the liquids than solids. Okay, this is something very much important. Now, whenever you do the barium swallow, okay, you can very clearly see here, whenever you see the barium swallow, okay, the patient is taking the barium. Now, the barium, it's coming to the walls of the esophagus. Now, the esophagus, see here, in the lower esophageal sphincter region, the esophagus is tightly contracted. Okay, the esophagus is tightly contracted. So, how the esophagus is looking like? Like the esophagus is something like this. Okay, now the esophagus is like this. It's like a board beak. Okay, so let me write. When the patient is taking barium swallow, the patient is going to have bird beak appearance. Yes, Ashutosh, you are true. Bird beak appearance. Okay, in some books mention not only bird beak, rat tail appearance also. Rat tail appearance. But this rat tail appearance is also seen in the cancers, esophageal cancer. In rat tail appearance is also going to be seen in the esophageal cancer. Okay, now what is the investigation of choice? Any idea, guys? Okay, if you imagine I am the person who is having this Achalasia Cardia, my lower esophageal sphincter is not going to be relaxed. Okay, it is not relaxing, so I will be having difficulty in the swallowing of the food. Okay, I will be having difficulty in swallowing the food. What is the investigation of choice? Any idea? Any idea, Ashutosh? What is the investigation of choice? I will show you the image also. So what is this study which I have shown here? Yes, it's the manometry, high resolution. Okay, high resolution manometry. Okay, high resolution manometry. They go here. So this is the normal person. Whenever he is swallowing, whenever he is swallowing, see, you can see the normal thing. Okay, manometry, the esophagus is getting dilated. Okay, it's everything okay. Contractions are there. Okay, contractions are there. Okay, I should say, sir, in Achalasia Cardia, not only the lower esophageal sphincter is tightly contracting, to be very frank, the contractions in the esophagus are also lost, sir. The contractions, the esophagus is also not contracting. Okay, so that's why in a patient who is having achalasia, there is no contraction. Okay, there is no contraction in the esophagus. Okay, so investigation of choice is high resolution manometry. Okay, now these patients are at risk of, Ashutosh, can you tell me, Ashutosh, fun mode, what happened? Okay, what is these patients are at risk of? If I am the patient who is having this Achalasia Cardia, I am at risk of what? I am at risk of developing squamous cell carcinoma. Okay, I am at risk of developing squamous cell carcinoma, sir, of esophagus. Okay, squamous cell carcinoma of the esophagus. Where? In which region? What is the most common site of the squamous cell carcinoma of the esophagus? Upper 1/3, middle 1/3 or lower 1/3? Use your logic and tell me. What might be the most common site? Lower 1/3. Okay, so lower 1/3. Okay, so risk of squamous cell carcinoma is going to be seen, but too in the lower 1/3, sir. Okay, but if this specifically asks you what is the most common site of squamous cell carcinoma, the most common site of the squamous cell carcinoma is always middle 1/3. Okay, most common site of squamous cell carcinoma is always middle 1/3. In India also always middle 1/3, but in this condition it's going to be the lower 1/3. Okay, in this condition it's going to be, okay, let me write here clearly here. Most common site of squamous cell carcinoma of esophagus. Okay, most common site of the squamous cell carcinoma of the esophagus is middle one third. In one of the questions was asking, one of the exams, what is the most common site of the squamous cell carcinoma in India? In India also, it is middle one third. Okay, in Achalasia Cardia, if they have specifically asked you what is the most common site of the squamous cell carcinoma, in Achalasia Cardia it is lower one third. Okay, usually in lower one third, adenocarcinoma of the esophagus is seen. Adenocarcinoma of the esophagus, totally different variety. We will discuss about that later. Okay, so completed, sir. Okay, next after this, what else I want you to know here is associations. Achalasia Cardia is associated with which disorders? Any idea? Who will develop this Achalasia Cardia? It is number 1, Chagas disease. Okay, Chagas disease. Not only this, sarcoidosis. Okay, diabetes mellitus and okay, diabetes mellitus, amyloidosis. Okay, so these are the conditions which are associated. Okay, these are the T. cruzi, trypanosoma cruzi, Ashutosh, you are true. Trypanosoma cruzi is going to cause the Chagas disease. Okay, sleeping sickness. Okay, African sleeping sickness. So Chagas disease, sarcoidosis, amyloidosis, and diabetes mellitus. These are the systemic disorders. Okay, amyloidosis, diabetes mellitus. Now they can develop this Achalasia Cardia. Okay, Achalasia Cardia, sir. Done. Now, what else? What else you should know is the treatment part. Treatment. Guys, any idea about the treatment? What you have to do? So the lower esophageal sphincter is contracting. Too much contraction of the lower esophageal sphincter. Now what you have to do? You have to relax it. You have to make the lower esophageal sphincter relax. How you can do that? Calcium channel blockers. So the calcium channel blockers, the calcium is responsible for the muscle contraction. Calcium channel blockers can cause muscle relaxation. Calcium channel blockers can be used. Okay, so that's a drug you can use. What you can do? Sorry, I beg your pardon. So you can use the calcium channel blockers. Okay. Apart from calcium channel blockers, what else can be done? So you know there is this one toxin called as a Botox toxin. Botox is going to cause the smooth muscle relaxation. So it's going to cause the muscle relaxation. Okay, Botox toxin can cause muscle relaxation. So intrasphincteric injection of Botox toxin. Okay, intrasphincteric Botox injections can be used. Apart from that, what else can be done? The surgery, the surgical management. Any idea? Okay, let me write here the surgery. Any idea? Okay, which surgery is done in the condition of Achalasia Cardia? Ashutosh. The surgery is going to start with the name like H. That's called as a modified. Okay. Heller's, yes. Myotomy. So modified Heller's myotomy. Myotomy is in the name itself. It is there. Myotomy. Certain part of the muscle, certain muscle fibers are going to be cut, removed. Tomy means just removed. Okay. So modified Heller's myotomy is the gold standard surgery. The gold standard surgery that is done as a treatment of Achalasia Cardia. Intrasphincteric Botox injections can be used. Calcium channel blockers can be used. Okay. So done, sir. Okay. Done. Achalasia Cardia is also completed. Now after Achalasia Cardia, guys, can you tell me what exactly is this image that I am showing you here? What exactly is this image, sir, that I am showing you here? Any idea, guys? Hello, Meena Sadat. Meena Sadat, can you tell me what is this image that I am showing you? Where is fun mode? Fun mode. Varun Kashyap, where are you guys? Candidas is no fun mode. You're not sure? Ashutosh, are you sure? What exactly is it? How it is looking like? How it's looking like? It's looking like a corkscrew. It's looking like a corkscrew, right? The one, the screw which is used to open the champagne bottles. Okay, the corkscrew, sir. Okay. So the condition is diffuse. Okay. That's not a cucumber. The condition is, the second disorder is diffuse esophageal spasm. Okay, yes, Dheeraj, you are true. This is the diffuse esophageal spasm. Now, this diffuse esophageal spasm, it is seen again. It is seen in males or females. It's going to be seen again in females, but middle-aged females. Okay, middle-aged females. It's going to be seen in the middle-aged females. Now, because of, see, we don't know the exact reason why this is happening. We don't know the exact reason. The entire esophagus is now contracting. Okay, the entire esophagus are going to show the powerful contractions, the diffuse in the entire esophagus. The esophagus is contracting, sir. So when the esophagus, starting from here, okay, when the esophagus is the esophagus is passing through the thorax, right? When the esophagus is contracting with so much, intensity, definitely the patient is going to have pain, chest pain, sir. So he will think that he is having heart attack. Okay, so very severe pain. So the patient is going to have, of course, dysphagia is going to be seen. Okay, dysphagia is going to be seen, but in your exams, they will say the patient is having chest pain. And it mimics. It mimics what? It mimics myocardial infarction. It mimics the MI, the heart attack. Okay, so they will give you some hints. When the patient is going to have, the symptoms, chest pain, they are going to be seen, especially during stress or taking cold, substances, with the cold fluids aggravated. The patient is going to have the symptoms. The pain is going to be aggravated with stress. Okay, during stress as well as cold fluids. Okay. Now, if you ask these patients to go for the barium swallow, see, now you can very clearly see. So, these are the contracted regions. See, in these regions, the esophagus is contracting. Okay, the esophagus is contracting, sir. So much contraction. So, how it is looking like? It's looking like a corkscrew. Corkscrew esophagus, corkscrew esophagus also called, this is also called as rosary bead appearance. Okay, rosary bead appearance. Okay, now there is so much contraction of the muscles, so much contractions, diffuse contractions. Now, can you tell me what is the treatment in this condition? It's mimicking the pain, chest pain. Can you tell me what is the treatment in this condition? Ashutosh, fun mode. Yeah, it's angina-like. Can you tell me what is the treatment? Simple, calcium channel blockers. Okay, calcium channel blockers. Calcium channel blockers. Okay, calcium channel blockers, right? So, done. Diffuse esophageal spasm. Mainly they will ask you is the image based question. This is the image based question that will give you in your exam. Okay, yes, true fun mode, you are true. Okay, is the diffuse esophageal spasm. Now, after diffuse esophageal spasm, the next topic which I want you to know is gastroesophageal reflux disease. Okay, GERD, gastroesophageal reflux disease. In the name itself, it's there. They go gastro means from the stomach into the esophagus. From the stomach into the esophagus, there is a reflux. Reflux of what? Reflux of the acid. The acid from the stomach is getting refluxed back. It's getting refluxed back into the esophagus. Okay. So, this is the gastroesophageal reflux disease. Let me tell you some important points here. What's the lower esophageal sphincter is there, right? Let me write normal pressure in lower esophageal sphincter. Okay, the lower esophageal sphincter is contracting. If you measure the pressure here, with how much pressure it is contracting, the pressure is somewhere between 10 to 25 mm Hg. With this much pressure. Now what happens if it is not contracting properly? It is not contracting properly, sir. So pressure less than, if the pressure, if it is less than 10 mmHg, if the pressure is less than 10 mmHg, what happens? Now it is not contracting properly, so the gastric contents are going to reflux back into the esophagus, so that will lead to GERD. Okay, so the pressure, if the lower esophageal sphincter, if it is not contracting, if the pressure in the lower esophageal sphincter is less than 10 mmHg, it causes what? It causes GERD, GERD. Okay, now what is the most common symptom? What is the most common symptom, sir? Any idea? So now if I take the food, okay, after taking the food, now the acid is going to reflux back. The acid is going to reflux back into the esophagus, so I will start to feel heartburn. Okay, so what I am going to have? Heartburn, sir. Okay, heartburn is the symptom that's going to be seen. What is the investigation of choice? What is the gold standard? Okay, what is the gold standard investigation of the investigation that's going to be done in this condition? Okay, so this is the investigation, sir. Okay, now are you able to appreciate? See, she is carrying some, like, a device. Now this device, see, it's going through her nose and it's going into her esophagus. Okay, so there is a sensor, which is placed in her esophagus, Now, whenever the gastric acid is regurgitating back, whenever the gastric acid is refluxing back into the esophagus, now it will sense. Okay, it's sensing what? It's sensing the pH. It is sensing the pH in the esophagus. More the number of times reflux, it senses. Okay, so yes, one more, you are true. The gold standard investigation of choice is 24 hour. Okay, it is 24 hours ambulatory pH monitoring. Okay, so it's the ambulatory pH monitoring. 24 hours ambulatory pH monitoring is the gold standard investigation. Image based question important. Okay, image based question is important, sir. Okay, 24 hours pH monitoring is the gold standard investigation that is done in the gastroesophageal reflux disease. Okay, now the points which I want you to know is, sir, if I am having gastroesophageal reflux disease, I am the person. Okay, every time I am having this reflux, sir, what might be the complications? Now acid is coming into the esophagus. Acid was supposed to be present in the stomach. If acid is coming into the esophagus, now esophagus is worried with this acid. Esophagus cannot take the stress. Esophagus cannot tolerate the acid. So do you know what happens? So the lower esophagus, or in the lower esophagus, the squamous epithelium, normally squamous epithelium is there. So the squamous epithelium is converted into columnar epithelium. The squamous epithelium is going to be converted into columnar epithelium. Okay, so there will be metaplasia. So there will be metaplasia. We'll discuss about that. So there is going to be Barrett's esophagus. Esophagus. That's going to be Barrett's esophagus. So Barrett's esophagus is a complication of, gastroesophageal reflux disease. Okay. Yes, Barrett's esophagus is an example of metaplasia. We'll discuss about this in a minute. Okay, done, sir. Now, after this, let's discuss about this image which I am showing you. So here in the endoscopy, in the esophagus, are you able to appreciate this structure? This ring-like structure, this is the mucosa. The mucosa is forming a ring-like structure. Okay, this is endoscopy, sir. Okay, this is not colonoscopy and that's not hymen. Don't say that's hymen. Okay, this is not, sorry, colposcopy. Don't say it's hymen. Okay, so what exactly is it? What exactly is this image? And here in the barium swallow, you can clearly see this, like, the web-like structure. Okay, it's coming. It's narrowing the esophageal lumen. What is this? Anyone? Fun mode. Can anyone tell me? Can anyone tell me what exactly is this? Image based question important for the PG exams. Let me write here important points. The first complication which I have discussed is the Barrett's esophagus. Okay. The second complication, those who ever have developed this GERD, gastroesophageal reflux disease, these patients can develop, any idea? Not Barrett's fun mode. That's not Barrett's. Schatzki's ring. Okay, so this ring-like structure, the ring-like mucosal extension, okay, so this is called as Schatzki's ring. The question that will come in your exam is Schatzki's ring is seen in gastroesophageal reflux disease as a complication of gastroesophageal reflux disease. This Schatzki's ring can occur. Okay, how I used to remember is देखो, now this is esophagus, this is the stomach. Now acid is regurgitating back into the esophagus. Now esophagus, what it is doing is, esophagus is going to put a gate. Okay, esophagus, it is putting a gate to prevent the acidic reflux. Okay, so that acid is not going further up into the esophagus. Okay, so that's like I used to remember something like that, sir. Okay, Schatzki's ring is going to be seen as a complication of GERD. Okay, and any other complications? Third complication is going to be adenocarcinoma. Okay, adenocarcinoma of esophagus. So those whoever have this GERD, gastroesophageal reflux, that's not good. Okay, acid is refluxing back into the esophagus. Esophagus cannot tolerate the acid. So first it will undergo metaplastic changes. Okay, metaplastic changes, that's the Barrett's esophagus. Later on, if there is continuous insult, if the insult is continuing insult, there is a possibility of adenocarcinoma of the esophagus. Okay, now which is the most common complication out of all this? What is the most common complication because of GERD? What is the most common complication? None of these three. Okay, none of these three. The most common complication is going to be just inflammation, sir. That is reflux, esophagitis. It's the most common. Okay, just inflammation, reflux, esophagitis. Because of the reflux, there is esophagitis. Done. Okay. Now, after this, Schatzki's ring, let's discuss about this image. Guys, can you tell me what exactly is happening here? This endoscopic image I am showing you. Come on, fun mode. Ashutosh. Goblet cell is the hallmark goblet cells. That I will discuss. Okay, what exactly you are trying to say is the presence of the goblet cells in the esophagus. It is a hallmark of Barrett's esophagus. Yes, I will come to that. Area, Barrett's esophagus. I understood. Meena Sadat, what exactly is this? Rohina Rashid, excellent, you are true. Excellent. It's the Mallory-Weiss tears. These are the tears, these are the lacerations. Which are seen in the esophagus. Okay, lacerations in the mucosa. Okay, now the topic which I am going to discuss here is Mallory. Yes, Vardhan, you are also true. Mallory-Weiss tear. Vardhan, you are true. Rohina Rashid, you are also true. Okay, Mallory-Weiss tears. Now imagine after this class, I'm going to go and having a binge drinking. Okay, I'm having the binge drinking, sir, after this class. Okay, anyway, I'm not going to do that. So this Mallory-Weiss tears are going to be seen in alcoholics. Okay, it's going to be seen in alcoholics. See, what I'm doing is I'm going to drink. Okay, lots of alcohol. Along with this alcohol, I'm going to have some munching, right? Some chips, pakoda kind of thing. I'm going to eat. I'm going to take, right? So what happens is, so the alcoholics are going to have the vomitings after drinking so much amount of alcohol. These guys are going to have the vomitings. Okay, forceful vomitings. So now, whenever they are going to have this forced vomiting with a closed glottis, the glottis is closed. Now they are going to have a forced vomiting. Now what happens? Just think. I used to think in a simple way. Dekho, sir, here all the chips pieces, all the sharp pieces, the food pieces are there. Okay. Now whenever the patient, this person is the full alcoholic. Now after drinking this alcohol, he is going to have the vomiting. All the sharp pieces are going to do what? They are going to come up like this. While they are coming up forcefully, they will cause lacerations. They will tear the mucosa. Okay, they will cause tears in the mucosa, sir. So these tears are going to bleed. No doubt, these tears are going to be bleed. So these are going to be longitudinal tears. Okay, so let's clear this and let me write. So this Mallory-Weiss tears are going to be superficial, not deep, just superficial. Superficial longitudinal tears, okay, in mucosa, okay, in mucosa sub. Okay, what is the most common site that they can ask you? Most common site. The most common site is going to be the lower one third of the esophagus near the gastroesophageal junction. Okay, the lower esophagus is going to be most commonly affected, right? With such a high velocity, when these food particles, when they are going into, when they are entering into the esophagus, high pressure is going to be there. Okay, so most common site is going to be gastro. Okay, gastroesophageal junction. Okay, gastroesophageal junction near cardia. Okay, cardia is a part of the stomach. I will show you later. So, gastroesophageal junction is going to be most commonly affected. Now, what are the clinical features, sir? If I am the patient, see, if I am the patient, if I am an alcoholic, I am a binge drinker. After drinking, I am going to have my vomitings. So, what kind of symptoms are going to be seen tomorrow? Like, these tears are there, longitudinal lacerations are seen in my esophagus. So, there will be hematemesis whenever, whenever I am doing vomitings, blood will come. Okay, blood is going to come, sir. So, hematemesis. Okay, hematemesis. Okay, hematemesis is going to be seen. So, these are some important points which I want you to know. Next, after Mallory-Weiss tears, let me discuss about Boerhaave's. Okay. So, what exactly is Boerhaave syndrome? Okay, so what exactly is Boerhaave syndrome? See, if all the 4 layers in the esophagus, because of some reason, if all the 4 layers are ruptured, okay, if all the 4 layers, see this Mallory-Weiss tears, it's the superficial laceration, just superficial cuts. Okay, only mucosa is affected, hardly submucosa. But if there is complete damage for the 4 layers, so the mucosa, submucosa, muscularis and serosa, all are damaged. Now what happens? Now you are going to have a hole, sir. Now you are having a hole in the esophageal wall. Okay, so right in Boerhaave syndrome, what happens is all 4 layers, right? All 4 layers of esophagus. Okay, all 4 layers are ruptured. All 4 layers are affected, sir. What is the most common site? They will ask you, this is the question asked in the exam, most common site. The most common site is going to be left side posterolateral. Okay, now first let me tell you. Most common site is lower 1/3. 1/3 of esophagus. Okay, lower 1/3. Okay, lower 1/3 of the esophagus. Now in lower 1/3 also, see this is the esophagus, lower 1/3 of the esophagus. There will be anterior wall, posterior wall, lateral walls will be there. Okay, where exactly, sir? So left, okay, left posterolateral area. Okay, lower 1/3 of the esophagus, left side posterolateral wall. Okay, well, because there are 2 lateral sides, right? Right lateral, left lateral. Okay, so left posterolateral wall is going to be most common site for this rupture. Okay, now what happens? Imagine I am the person. Okay, I am having the rupture of this esophagus. The 4 layers are ruptured, sir. Okay, now there is a hole. Now what happens? So now when I am talking, the air is entering into my trachea. The air will also going to enter into my esophagus. Normally when I open my mouth, the air will enter into my esophagus, sir, no doubt. The air is going to the esophagus. Now there is a hole in the esophagus, there is a rupture, the esophagus is ruptured. Now this air will start to enter into the mediastinum. Okay, so what happens? There is air, okay, there is air or even food. Whenever the person is taking some food, the air or food, they will enter where? They will enter into the mediastinum. Okay, so air or food in the mediastinum, sir. So that will cause what? Now in the mediastinum, air is there and food particles are there. That's not something good. So there will be mediastinitis. So these are the complications. Will be mediastinitis. Okay, our air is there. So pneumo, air is there, sir. Pneumo mediastinum. Okay, pneumomediastinum, sir. Now this air, now the air have entered into the mediastinum. Now all this air, it will pass through all the layers. Air always want to come up. So all this air, it will pass through all the muscle layers, and at the end of the day, it will come and settle below the skin. So now you can see small air pockets that are seen under the skin. So this is called as subcutaneous, below the skin, subcutaneous emphysema air pockets. Okay, there will be subcutaneous subcutaneous emphysema. Okay, subcutaneous emphysema is going to be seen. Now, see here, now this patient, he have taken what? He have taken the barium swallow. Okay, he have taken the barium swallow. But from this area, there is a rupture. All this barium, now it is leaking into the mediastinum. The barium is leaking into the mediastinum. Okay, so actually you are not supposed to do this barium swallow steady, but you don't know, you just done the barium swallow. From this ruptured area, the barium or this contrast is leaking into the mediastinum. Okay, so image based question that can come up in your exam. So air in the mediastinum, pneumomediastinum. Okay, pneumomediastinum, subcutaneous emphysema. Okay, is going to be seen. Whenever you do like a subcutaneous emphysema, whenever you try to just just press it, it'll be like crackles are going to be seen, small sounds, but sounds will be seen, sir. Okay. Now here this is a beautiful image which I have found it on the internet. Mallory-Weiss syndrome and Boerhaave syndrome. In Mallory-Weiss syndrome, see the patient is an alcoholic. Okay, the patient is an alcoholic. He is going to do the vomitings continuously, regularly. So there will be superficial longitudinal lacerations which are going to be seen in the lower one third of the esophagus. Because of that, the patient is going to have the hematemesis. Okay, longitudinal tears. Okay, upper GI bleeding can be seen. So here in Boerhaave, what is the problem? The problem is complete rupture. Esophagus, all 4 layers are completely ruptured. Okay, they go complete rupture in the lower part of the esophagus. So the patient is going to have subcutaneous emphysema. These are more dangerous conditions, or actually it can kill the patient. Okay. Okay. Done. Okay. Now in these patients, one more important point which I want you to know is these patients are going to have Hartmann signs. Okay. So not Hartmann, sorry, Hammond signs. Okay. So Hammond sign is going to be seen. So what exactly is this Hammond sign? Hammond sign is whenever you try to do the auscultation. Okay, whenever you try to do the auscultation, so you are going to see the crunching sound. Because of what? Air is there. Air is there in the mediastinum due to pneumomediastinum. Okay, due to pneumomediastinum, there will be crunching sound that is heard. That's called as a Hammond sign. Okay, Hammond sign. Hammond sign is because of pneumomediastinum. It's a crunching sound, sir. Done. So with this, Mallory-Weiss tears as well as Boerhaave syndrome is also completed. Now, after that, the next esophageal disorder which I want you to know is, look here and tell me, what is this? What is the problem? So here the esophagus, are you able to appreciate this ring appearance? There are many ring-like appearance. Here also, so many esophageal rings are seen on endoscopy. Okay, if you do biopsy, so many inflammatory cells. These are all the eosinophils. Okay, so many inflammatory cells, eosinophils are going to be seen. Okay, what exactly is this, sir? Okay, any idea? Ashutosh, fun mode, thriller, mean Sadat, Vardhan. Guys, can you tell me what exactly is this condition? Image based question. Imagine this is the question that came in your exam. What if this question came in your exam? These are the questions that usually come. Okay. Can you tell me what is the problem here? Come on, Ashutosh, Dheeraj, fun mode, Meena Sadat, Sharad. Just wait, I think there is some buffering going on. Okay, there is some issue with my, turn it in this mobile. Okay, but anyway, so the condition here it is feline esophagus. Okay, so this is feline esophagitis. Okay, feline esophagitis. Okay, the esophagus is going to be looking like a cat esophagus, a feline in the cats. Okay, the esophagus is going to be something like this, feline esophagus, esophagitis. Now, it's an example of allergic esophagitis. Okay, allergic esophagitis. Why allergies, sir? See, during allergies, when the patient is having allergies, which cells are going to be elevated? Eosinophils. So those patients who are having eosinophilia, these eosinophils will start to enter into the esophagus and causing inflammation in the esophagus. Okay, so allergic esophagitis, on histology what you will see? Sir, on histology you will see eosinophilic infiltrates. Okay, eosinophilic infiltrates which are seen in the esophagus. More number of eosinophils are going to be seen, sir. Now, this study, okay, this investigation which we have done here, it's a double contrast esophagogram. Okay, that's not a barium swallow. It is double contrast, which means air is also used along with the contrast. Air is also used. So, double contrast esophagogram. Okay, double contrast esophagogram. Now, on this double contrast esophagogram, what kind of appearance is seen? Herringbone pattern. Okay, you just check what exactly is the herringbone pattern. You will understand in the internet herringbone pattern, sir. Here you are able to see this herringbone pattern, sir. They are just like, okay, herringbones. Okay, usually we will have the carpet kind of thing, right? Carpet kind of thing is a herringbone. Okay, so what you are seeing is herringbone pattern. So herringbone pattern is seen on the double contrast esophagogram. Due to concentric mucosal thickening, there's going to be herringbone pattern. Now, they can ask you something like this, sir. Now the esophagus, usually trachea is having C-shaped rings, shaped cartilaginous rings are seen. Okay, C-shaped cartilaginous rings are seen for the trachea. That's okay. But now in this condition, you are able to see the ringed appearance in the esophagus. So this is called as trachealization. Of what? Trachealization of esophagus. So trachealization of the esophagus is seen in which condition? In feline esophagitis. In feline esophagitis, the esophagus, the morphology of the esophagus, it looks like a trachea during endoscopy because of this ringed appearance. So trachealization of the esophagus. Done. Okay. So what are the important points? Feline esophagitis, it's an example of allergic esophagitis. Eosinophilic infiltrates are going to be seen on the histology. On double contrast esophagogram, you are going to see the herringbone pattern. If they ask you where trachealization of the esophagus is seen, is going to be seen in feline esophagitis. Done. Next. Guys, here, are you able to tell me what exactly is happening? Are you guys able to tell me what exactly is happening here? So this is again endoscopy of the esophagus. Now, in the lowermost part of the esophagus, are you able to appreciate this red color mucosal, red velvety mucosa? It is seen in the lower one third of the esophagus. What is this, sir? What is happening in this area? Sir, this is a classical example of Barrett's esophagus. Okay, Barrett's esophagus, sir. Okay, now let's discuss about the Barrett's esophagus one by one. Important points. Okay, so Barrett's esophagus, it's going to be seen in males or females? Most commonly they are seen in the males, sir. In which age group? 30 years to 50 years. Okay, 30 to 50 years is the most common age group for the Barrett's esophagus. Now, why Barrett's? Why? You already know it's a complication of what? Complication of GERD, gastroesophageal reflux disease. It's a complication of GERD, sir. Now, let me put some normal points. Normal epithelial lining in the esophagus. Normal epithelial lining, sir. in the esophagus is stratified squamous epithelium. Okay, stratified squamous epithelium. It's a squamous epithelium, sir. In my esophagus, there is going to be squamous epithelium. There is going to be squamous epithelium. But whenever there is more and more acidic damage, acid is getting refluxed back into my esophagus. Usually, once in a while, we'll have the acidic reflux. You and me usually will have the acidic reflux. Okay, whenever we took a lot of food. Okay, usually there is going to be reflux. But continuously, if every day if it is happening, throughout the day if it is happening, that's called as a gastroesophageal reflux disease. It's happening all the day. Okay, all over the day. So now whenever this acid is coming, now what esophagus will do? Esophagus will first try to adapt. It will try to adapt for that acidic damage. So squamous epithelium is not resistant. Squamous epithelium is not resistant for the acidic damage. Then who is more resistant for acidic damage? It's the columnar epithelium. The columnar epithelium which is present in the intestines. Okay, so this squamous epithelium is going to be converted into columnar epithelium. Okay, columnar epithelium. Okay, so squamous epithelium is getting converted into the columnar epithelium. Now, not only just columnar epithelium, sir, acid is coming, right? Acid is coming to protect the esophagus from this acidic damage. Now, the mucus also should be secreted in the esophagus. The mucus should be secreted in the esophagus. Who will secrete the mucus? So, the stratified squamous epithelium is getting replaced with columnar epithelium along with goblet cells. Okay, along with the goblet cells. Goblet cells are seen in the intestines, sir, not in the esophagus. In the esophagus, goblet cells are normally not seen. In the stomach also, goblet cells are not seen. But where the goblet cells are seen? The goblet cells are seen in the intestines. So that's why this is called as intestinal type of metaplasia. Okay, this is called as what? This is called as intestinal type of what? It's an intestinal type of columnar metaplasia. It's an intestinal type of columnar metaplasia. Why the word intestinal? Intestinal type due to presence of goblet cells. Why? Because columnar epithelium is also there in the stomach. In the stomach also columnar epithelium is there, but goblet cells are not there. Okay. So you can very clearly see here in the esophagus, now you are having all these glands. Normally in the esophagus, these glands are not there. Now see, there are so many glands present. So many glands present. Okay. Normally it should be stratified squamous epithelium. Now it is replaced with columnar epithelium along with the goblet cells. Okay. So done, sir. So it's an intestinal type of metaplasia. Intestinal type of metaplasia. Now they will ask you in the general pathology also I have discussed. Sir, what is something? Let me write here. Intestinal type of metaplasia. Sir, what exactly is metaplasia? You know it. Metaplasia means one type of cell is changing into the other type of cell. So squamous epithelium is being replaced with the columnar epithelium. One type of cell is replaced with other type of cell. Okay, metaplasia. Now why metaplasia? Any idea, guys? Metaplasia is due to stem cell reprogramming. Okay, don't forget this. Stem cell reprogramming can lead to metaplasia. What is the most common site? The most common site is going to be lower 1/3. Okay, lower 1/3 of the esophagus is going to be most commonly affected with this Barrett's esophagus, with the Barrett's esophagus. Okay. Now, whoever have this Barrett's esophagus, they go here. You can very clearly see, sir, these. Okay, these are the goblet cells. Okay, all these are the goblet cells which are secreting the mucin. They are secreting the mucin, sir. The goblet cells are secreting the mucin. Okay, so one more question which can come in your exam is, sir, these goblet cells are the mucin. The mucin is stained with which dye? What is the stain used? What is the stain used for this? Goblet cells are the mucin. It is Alcian blue. Okay, Alcian blue, sir. So Alcian blue is the stain. Okay, used for the mucus, Alcian blue. So whenever you take a biopsy from the lower 1/3 of the esophagus and whenever you stain with the Alcian blue, normally there is no staining. But in Barrett's esophagus, due to the presence of that mucin, due to the presence of the goblet cells and the content of the goblet cells, that's the mucin. Okay, mucus. The Alcian blue is going to come positive. Okay, Alcian blue is going to come positive. So blue color, sir. The blue color here, it represents the mucin, mucus production. Mucus is getting produced. Okay, and right, Barrett's esophagus. Barrett's esophagus is going to increase what? It increases risk of what? It increases the risk of just let me write here. It increases the risk of adenocarcinoma of esophagus. It increases the risk of adenocarcinoma of the esophagus, not the squamous cell cancer. Adenocarcinoma of the esophagus. Now, whoever have this Barrett's esophagus, now they are more likely to develop. Okay, they are more likely to develop adenocarcinoma of the esophagus. What is the most common site of the adenocarcinoma of the esophagus? Now you know. The adenocarcinoma of the esophagus is going to be seen most common in lower one-third. Simple. Why? Because Barrett's esophagus is most common in lower one-third. So adenocarcinoma is also going to be most commonly seen in the lower one-third. But if someone asks you, what is the most common esophageal cancer? The most common esophageal cancer is squamous cell carcinoma. Squamous cell carcinoma is seen in middle one-third. Okay, squamous cell carcinoma is the most common esophageal cancer. It is seen in the middle one-third. But adenocarcinoma is seen in lower one-third because because Barrett's esophagus occurs in the lower one-third. Okay. Okay. Now, one question: Barrett's esophagus, is it reversible? Is it reversible or not? Yes, it is reversible, sir. Metaplasia, sir, it is reversible. Whenever you take out this acidic insult, whenever you decreases the gastroesophageal reflux, whenever you decreases the reflux of acid, automatically the Barrett's esophagus is going to be replaced with normal epithelium. Okay, it is reversible, absolutely reversible. Okay. Having said that, what else I need to teach you is, sir, here this is the adenocarcinoma of the esophagus. Okay, that's in the lower one-third of the esophagus is the adenocarcinoma. Okay, adenocarcinoma, it's due to Barrett's esophagus. Okay, lower one-third. Okay, lower one-third. Now, look at this and tell me. Image-based question again. Image-based question, sir. So, here, not very much clear, but I hope you can appreciate still that there are ulcers in the esophagus. There are ulcers in the esophagus, sir. So, these ulcers are like punched ulcers. These are like punched ulcers. Okay. See, the punched out ulcers in the esophagus is seen in which condition? Guys, any idea? So, there are punched out. You know the punching machine, right? The punching machine. Okay. So, punched out ulcers is seen in which condition? Any idea? These punched out ulcers in the esophagus are seen in herpes infections. Herpes esophagitis. Okay, herpes esophagitis. Whenever the person gets the herpes virus, okay, the herpes can infect the esophagus also. So, herpes esophagitis. Okay, the patient is going to have sharp delineated ulcers. Okay, sharp delineated ulcers. Okay, that are also seen in the lower part of the esophagus. Okay, in the lower esophagus. So, herpes esophagitis. On microscopic examination, what you will see? On microscopic examination, what is seen? Okay, so there is intracellular, okay, intracellular ground glass appearance. On microscope, I will show you the image. Intracellular. Okay, intracellular. Okay, there is intracellular ground glass appearance. Ground glass appearance. Okay, see, now this is the ground glass. You know it, like how it is looking. It's not transparent, sir. It's not transparent. Okay, it's almost translucent. Okay, so if a patient, say here, very clear. Okay, punched out ulcers seen in herpes infection. If the patient is having herpes infection, he's going to have the punched out ulcers. Now, here if you look at the cells, in the cells, it's very clear. It's like, you know, it's a ground glass. Okay, ground glass kind of appearance. Okay, ground glass appearance is going to be seen in herpes esophagitis. Okay, herpes esophagitis. Done. Now, say again, here, dekho. What are you seeing here is the cells, the esophageal biopsy. Now, what I'm discussing here is the esophageal biopsy is showing these cells, okay, with these inclusions. See, these cells are looking like a owl eye. See, this is looking like a owl eye, sir, like a owl eye. See, this owl eye appearance, it is seen, it's characteristic of which type of esophagitis? Let me tell you, there is something called as CMV esophagitis, cytomegalovirus. Cytomegalovirus, CMV esophagitis. Okay, in CMV esophagitis, cytomegalovirus esophagitis, there is going to be owl-eyed appearance. You also know the owl-eye appearance of the nucleus is also seen in Reed-Steinberg cells. Okay, that's okay. The same owl-eyed appearance is going to be seen in CMV esophagitis. That's a one single liner. It's a one single liner which I want you to know. Just so herpes esophagitis is going to show the punched out ulcers with ground glass appearance, and CMV esophagitis is going to show owl-eyed appearance. Okay, owl-eyed appearance. Done. So after this, what else we have to know is the last topic in the esophagus. The last topic in the esophagus, the esophageal tumors. Okay, the last topic is esophageal. Actually, I thought to do the stomach also in this today's class, but we'll do the stomach in tomorrow's class. Esophageal tumors. So what is the most common benign tumor of the esophagus? The most common benign tumor of the esophagus. And what is the most common malignant tumor? You know it, both you know it. One thing you already know, most common malignant tumor. Most common malignant tumor, you know it. It is squamous cell carcinoma. Squamous cell carcinoma. Where? What is the most common site? Middle one third. What is the most common benign tumor then? It's a leiomyoma. Okay, leiomyoma, sir. So most common malignant is squamous cell carcinoma. It's seen in the middle one third. Not the most common, but one more malignant cancer. Okay, one more cancer of the esophagus is adenocarcinoma. Adenocarcinoma of esophagus. Where adenocarcinoma is going to be seen? Adenocarcinoma is going to be seen most commonly in the lower one third. Okay, lower one third, sir. Having said that, now let's discuss about the esophageal cancer. Okay, esophageal cancer. Who will get the esophageal cancer? Which individuals are at risk of esophageal cancer? Very important. See, देखो, what are the risk factors? Risk factors are smoking. Smoking is the number one risk factor, sir. Esophageal cancer. Okay, don't think that smokers are only going to get the lung cancer. No, esophageal cancer, kidney cancer, so many things. Okay, smoking is the number one killer. Okay, most of the students, I have heard this from many people saying that, I'm my grandfather is a smoker, my father is a smoker. Okay, they are smoking for the last 30 years. Okay, they haven't developed any lung cancer. They are healthy. See, let me tell you, if you are a smoker, 100% you will develop the lung cancer, sir. But even before manifesting, these smokers, even before they manifest the lung cancer, they will die with heart-related problems, coronary artery diseases. Okay, so smoking is that dangerous. Okay, don't ever smoke. Don't ever go into that arena of the smokers. Very bad. So it causes a lot of cancers, not just the lung cancer. Lung cancer will happen very lately. Even before developing the lung cancer, the patient will die with some coronary heart disease. Okay, atherosclerosis. Smoking can cause atherosclerosis. That atherosclerosis of the coronary artery can kill because of the myocardial infarction, right? Okay, anyway, let's come back. Risk factors: tobacco, orally or smoking, tobacco, you can chew it, or alcohol intake, alcoholics, deficiency of this vitamin A, C, E vitamins. These are the antioxidant vitamin, right? A, C, E, they are the antioxidants. They decrease the free radical formation. Free radicals can cause cancer. Deficiency of these antioxidants can lead to cancer, true. And deficiency of selenium, zinc, molybdenum. Okay, deficiency of this micronutrients or the these minerals. Achalasia cardia. Okay, Achalasia cardia. We have discussed Achalasia cardia is a risk factor of esophageal cancer, the squamous cell carcinoma of the esophagus, and Barrett's esophagus. True, Barrett's esophagus will cause adenocarcinoma, sir. Adenocarcinoma. Okay, that's the one important point. Achalasia cardia is a risk factor for squamous cell carcinoma. Plummer-Vinson syndrome. Sir, this is very important for your exam. At any cost, you should not leave this. Plummer-Vinson syndrome. Sir, what is this Plummer-Vinson syndrome? In Plummer-Vinson syndrome, the patient is going to have three things. Three features are going to be seen. Feature number one, the patient is going to have this web, mucosal webbing. Okay, mucosal web. Okay, we'll also call it as a esophageal web. Okay, in the esophagus there is web, sir, protrusion of the mucosa. Okay, protrusion of the mucosa. This is the esophageal web. And what you are seeing here, sir, the patient here is having hypochromic anemia. Okay, hypochromic, the RBCs are pale. Okay, microcytic hypochromic anemia. Okay, microcytic hypochromic anemia. Seen in which condition? Iron deficiency. The patient now here is having iron deficiency. When the patient is having iron deficiency, hemoglobin production is going to be less. When the hemoglobin is not there, the RBCs are going to be pale in color with small size, less than 85 milliliters. Okay, small size RBCs, less colorful RBCs. And iron deficiency. And these patients, when you look at their tongue, it's a large beefy tongue with atrophic glossitis, inflammation of the tongue, sir. Large beefy tongue with atrophy. Okay, atrophic glossitis. So if these three things are there in the patient, then it is called as Plummer-Vinson syndrome. Okay, Plummer-Vinson syndrome. The patient is going to have three features. What are these three features? Let me write. Esophageal web. Esophageal web, sir. Second feature is going to be iron deficiency anemia. Okay, iron deficiency anemia. And the third feature is going to be, okay, atrophic glossitis. Atrophic glossitis, sir. Okay, these are the three things which are seen in Plummer-Vinson syndrome. So those whoever develops this Plummer-Vinson syndrome, they are at risk of, developing esophageal cancer. Okay, just now I have explained you esophageal web means some mucosal protrusion which is usually seen in Plummer-Vinson syndrome. And infections like HPV, human papillomavirus infections. Okay, human papillomavirus infections in endemic areas. Okay, especially in endemic areas, the human papillomaviral infection of the human papillomavirus in the esophagus can lead to esophageal cancer. So these are the risk factors. Okay, these are the risk factors for development of the esophageal cancer. Okay, which cancer? Most common variant is squamous cell carcinoma of the esophagus. So if a patient is having esophageal cancer, now this is the esophagus, sir. Now there is a cancerous growth. Now if the patient is taking barium swallow, sir, there is a filling defect, right? This area of the esophagus is not, it is occupied. Okay, so contrast will come like this, and the contrast will go like this, go down. So there is going to be a filling defect. Okay, see here you can clearly see, sir, this is the esophageal cancer. Okay, because of this esophageal cancer, now the lower part of the esophagus, the contrast is going like a small, small column, in a very, small column it is going, sir. In a thin column I should say. So this is called as rat tail appearance. Okay, on barium swallow there is going to be rat tail appearance. It will be rat tail appearance. Okay, rat tail appearance. Rat tail appearance of the esophagus. After this, what else you should know? Okay, what else you should know? See, if you do histology, the most common variant is what? The most common variant is, most common type of esophageal cancer. Most common type is squamous cell carcinoma. Now, from your physiology, you would have studied, sir, the squamous cell carcinoma, what is the marker? What is the marker for the squamous cell carcinoma? Keratin pearls. Keratin is an intermediate filament. Okay, it's an intermediate filament. It's the intermediate filament present in the epithelial cells. Cancer of epithelial cells is called as carcinomas. Carcinomas are the cancer of epithelial cells. Now here also, it is a carcinoma, squamous cell carcinoma. In epithelial cells, which filaments are going to be there? Keratin filaments. So here, these are the keratin filaments, which is also called as the keratin pearls. So keratin pearls are seen. Okay. So on microscopic examination, histology, what you will see is keratin pearls. Okay, first, the structure is there, right? It's like round structure. So this is called as a nest like appearance of the tumor cells. Nest like appearance. The tumor cells are arranging in the form of a nest. and keratin pearls, which means the keratin filaments are positive. Keratin filaments are present in this tumor cell. Okay. Now one more important point. So if a person develops this esophageal cancer, okay, imagine there is a person who is developing esophageal cancer, sir. Okay. Now if he develops esophageal cancer, that's the most common type, the squamous cell carcinoma of the esophagus in the middle 1/3. Squamous cell carcinoma of the esophagus seen in the middle 1/3. This cancer, these cancerous cells, they will also produce certain hormones. These cancerous cells will produce some hormones, sir. So that is paraneoplastic symptoms. Paraneoplastic symptoms. So what are the paraneoplastic symptoms? Apart from neoplasia, apart from the cancerous symptoms. So the squamous cell carcinoma is associated with paraneoplastic symptoms. What are they? It's the hypercalcemia, sir. Hypercalcemia. Okay, hypercalcemia. Why hypercalcemia? Because this cancer, it is producing something like parathyroid hormone related peptide. Parathyroid hormone related peptide. Okay, these cancerous cells are producing parathyroid hormone related peptide or parathyroid hormone like substances. What parathyroid hormone will do? So parathyroid hormone will increase the blood calcium levels, leading to hypercalcemia. Okay, so as a paraneoplastic symptom, there will be hypercalcemia seen in squamous cell carcinoma of the esophagus. Okay, so important risk factors I have discussed. Okay, the images, esophageal web is important. So they will ask you, esophageal web, is it a risk factor for esophageal cancer? Yes, esophageal web is a risk factor. Okay, those patients whoever have these esophageal webs, they are at a risk of developing squamous cell carcinoma of the esophagus. True. Okay. So like that, okay. Keratin pearls, nest-like appearance, paraneoplastic symptoms like hypercalcemia are going to be seen. So with this, all the esophageal disorders, okay, I have completed all the esophageal disorders which are needed for your exam. If you know this much, enough, sir. In tomorrow's class, we'll discuss about the gastropathies, okay, problems related to the stomach that are chronic gastritis, acute gastritis, and also we'll discuss about the peptic ulcer disease, okay, Menintriers disease, gastric carcinoma, okay, Zollinger-Ellison syndrome. Okay, all those things like your gastric lymphoma, all these things will be discussed in the subsequent classes. Okay, hope the class is helpful. Okay, see you for today. Goodbye, guys. See you for today. Good night. Bye bye.